Hello everyone, this is Lطيفة العبيد, and today inshallah I will talk about the high risk pregnancy and gestational diabetes, which is one of the conditions if it happened to the mother considered to be a high risk pregnancy. And before I carry on with the class, I want to inform you that I will be continuing this class in English language. But if you want me to translate anything in Arabic or you didn't understand any point and you want me to clarify it with Arabic, I'm more than welcome to do so. Okay? Bismillah, to start. Our objectives for today would be to identify the concept of high-risk pregnancy, explain the factor contributing in high-risk pregnancy, define the concept of gestational diabetes, recognize the risk factor of gestational diabetes and its effect, discuss the management of gestational diabetes. So first thing first, the concept of high-risk pregnancy. A high-risk pregnancy is one that threatens the health or the life of the mother or her fetus. It often requires a specialized care from specially trained healthcare providers, meaning any sign, any symptom, any condition that affect the mother negatively during her pregnancy and put her at higher risk, her and her fetus, that means she require a close monitor by a specialized healthcare team and trained providers to protect the pregnancy. Okay, what is the factor that contribute in the incidence of high-risk pregnancy? Personal and biophysical factor, medical and obstetric factor, environmental factor, psychological factor, social and behavioral factor. We start with the first one, the personal and biophysical factor, meaning anything that relate to the mother and her biophysical profile that affect negatively in the fetus. The genetics, the nutrition status, the woman age, the parity, the pregnancy interval. So starting with a genetic consideration, for example, of the mother having an Rh incompatibility, meaning, or for example, if she has O plus blood type and the father having O minus blood type. So in this case, the woman should be given a medication during the pregnancy to protect her pregnancy and survive it. Chromosomal anomalies or multiple pregnancies. Nutritional status, of course, is an important factor if she's an overweight or massively obese or underweight or poorly nutrition. Woman age, one of the important factors. If the woman is too young to conceive or too old to conceive, meaning if she's younger than 18 years, which is adolescent, the uterus will not be fully mature to carry on with the pregnancy. Okay, it may carry on, but that will put her at a high risk to develop any complication because the uterus is not fully ready to conceive. Or if she is too old, meaning the uterus is exhausted, or if it's her first time, that will put her at higher risk also to develop any genetic anomalies and the increase of the risk of the prenatal mortality. The parity, and I want to refresh your memory. We know what is the meaning of parity. The para, you know, the G and the B. The G, the gravida, meaning gestation, the number of the pregnancy, and the bara, meaning the number of the delivery that the mother had. Okay? So, parity, elderly primigravida, meaning she's an older woman and she's a primigravida, meaning this is her first pregnancy, okay? Or a grandi multipara, meaning G6, remember? G6, sorry, let's write it better. G6. She has more than 6 pregnancies, okay? That will put her at higher risk. A grandi multipara is a high risk of pregnancy. Or a pregnancy interval or spaces less than 2 years interval is a risk factor. For example, let's give you an example to get this point. The mother gets pregnant in September 2020, okay? and then she delivered, and she get pregnant again in August 2021. Okay, so the space is really, really small between the two pregnancies. The uterus didn't take its time to fully recover. Okay, and that will put her at higher risk to develop any type of complication, especially one of the serious complications, which is the BPH, postpartum hemorrhage. Okay, so it should be the pregnancy should be planned. So this mother should be given a contraceptive health education to control her pregnancies and plan her pregnancies, and don't have this to occur. Okay, we come to the medical and obstetric factors. Medical factors, as obvious, such as chronic diseases, heart diseases or diabetes, thyroid problem, or any renal diseases. Obstetric factors, we have two parts in this, the maternal part and the fetal part. The maternal factor would be the presence of complication of a pregnancy as a pregnancy-induced hypertension, which is one of the other conditions that happen during the pregnancy and included in the high-risk pregnancy. We call it a preeclampsia, which affect the blood pressure of the woman. Gestational diabetes will affect the glucose levels. But in the induced hypertension, or pregnancy-induced hypertension, it will affect the blood pressure. It would be higher than what we are expecting. Second, a pregnancy that took place after infertility that was treated with hormones. For example, IVF pregnancies. Anemia, especially in severe anemia, exposed to viral infection, sexually transmitted diseases, placental abnormalities, for example, a placenta previa, previous cesarean deliveries, and previous abortions. We come to the fetal factors, malpresentation, meaning the fetus is presented in a not favorable presentation. The best presentation is the cephalic presentation, where the head is engaged downward, and the malpresentation that refers to aprecia presentation or a transfer presentation. A prematurity or low birth weight infant, fetal size twins, cord complication, congenital anomaly, and one of the factors is important, hydromenus. Hydromenus, we refer to it of the amniotic fluids that surrounds the baby, the fluids that surrounds the baby in the uterus. The normal range of these fluids, or the normal range index of the amniotic fluid, it's about 5 cm to 25 cm. Okay, so anything less than 5, we call it olighygromenous, and above 25, it's polyhydromenous. Okay, this is the normal range of the amniotic fluids. The environmental factor, radiation, chemical pollution, the level of housing safety and comfort as inadequate sanitation. So any environmental surroundings in the mother environment that affect the mother negatively, considered to be an environmental factors that contribute in a high risk pregnancy. Psychological factors, like a history of having psychological disorder, low self-esteem, lack of acceptance of the pregnancy itself, history of family abuse, inadequate support system. Social and behavioral factor. We come to the social. For example, the income, if she having a low income, that will affect her negatively. Social support, for example, if the mother having a positive social surrounding, that will affect her obviously in a positive way. And if it's the opposite, that will affect her in a negative way. Okay? Inadequate housing, lack of access of continued health care or emergency care. Of course, if the mother don't have the access for the healthcare centers near to her to monitor the pregnancy, that will put her at higher risk to develop any complication during the pregnancy without her knowing. lack of availability of health services. That's for the social. We come to the behavioral. So behavioral meaning any behaviors that the mother performed that affect her or her fetus in a negative way and will put her at higher risk to develop any complication, such as smoking or poor eating habit, inadequate exercises, alcohol consumption during the pregnancy, or doing any drug performing like cocaine, or drinking too much of coffee and consuming caffeine 6 or more cups per day. Okay, now we come to our condition, which we talked about earlier, the gestational diabetes. Okay, one of the condition that will, if it happened to the mother, that will put her at a high risk of pregnancy. Okay, gestational diabetes is an abnormal carbohydrates, fat, and a protein metabolism that is found for the first time during a pregnancy, usually in the second or the third trimester. It's fully treatable but requires careful medical supervision throughout the pregnancy. About 20% up to 50% of the affected women develop type 2 diabetes later in the life. The diagnosis is established by glucose tolerance testing, which we call the GTT. And the normal range or the normal result for the GTT is 7.8 millimoles per liter. If it's higher than that, then we consider it a gestational diabetes. Okay? It should be equal or less than that. So the mother will be giving a glucose solution in this test, and then after about 2 hours we do a blood glucose test, and if the result is higher than 7.8 millimole, then we consider it a gestational diabetes. Okay? A question may pop in your head now. What is the cause of gestational diabetes during the pregnancy? If the mother is medically free, surgically free, doesn't have any history of diabetes, but she developed the gestational diabetes during the pregnancy, what is the cause of that? I would answer you and say, during the hormonal change in the pregnancy, we have a hormone, what we call it HCG. This hormone, affect or has its own effect on the pancreas, which produce the insulin, right? Produce the insulin. So the mother will be sensitive to insulin, and that will increase the glucose level in her body and eventually develop a gestational diabetes. But after the delivery, when the HCG levels come down, she will get back to normal. But unfortunately, about 20% up to 50% of the women can develop the type 2 diabetes later in their life. Okay? We come to the risk factor that contribute in the occurrence of gestational diabetes. First, obesity. Of course, this is obvious. It's even a factor that affects in the diabetes mellitus, in the occurrence of diabetes mellitus, right? Family histories of diabetes in the first degree relative, meaning the mother or the sisters, maternal age older than 30 years, a previous birth of large baby over than 4.5 kilogram, a previous stillbirth, meaning the baby was delivered dead, unfortunately, previous baby with congenital anomaly, excessive weight gain during the pregnancy, polyhydramnios, as we explained earlier, too much amniotic fluid, a preeclampsia, which is the induced hypertension, what we also explained briefly, that affect the PPE, the BP, which is the blood pressure, having gestational diabetes in a previous pregnancy. All of these are the factors that increase the risk of developing gestational diabetes during the pregnancy. Okay, effect of the gestational diabetes in the pregnancy. So we have maternal effect and fetal effect. For the maternal effect, we have polyhydramnios, urinary tract infection, a pregnancy-induced hypertension, what we called it the preeclampsia, and premature rupture of the membrane. For the fetal and the neonatal effect, macrosomia, which is a large baby, more than 4.5 kilograms, and that will affect the baby in a negative way and increase the risk of the birth injury. Neonatal metabolic abnormalities, a preterm birth, polycythemia, which is an increase in the level of the RBCs, RDS, which is respiratory distress syndrome, hypoglycemia, childhood obesity, and a glucose intolerance later in their life. Okay, what is the management of the gestational diabetes? If the mother having a gestational diabetes, how we can manage that? We advise the woman to increase the folic acid intake to prevent any congenital anomalies, especially the neurological anomalies. Blood glucose levels should be monitored frequently 4 times a day, and insulin level adjusted to achieve a pre-meal blood sugar levels of 5 up to 6 millimole, and post-meal level less than 7.5 millimole, and monthly she need to check up on the HbA1c levels, and the measurement should be recommended to follow up with her. Exercises are very important and useful in the gestational diabetes cases, but we need to take under consideration that the mother having glucose, the glucose level is uncontrolled, meaning if she's going to exercise, she need to have a small snack in case, God forbid, she develop a hypoglycemic episode. Okay, and we need to teach her about how to differentiate between the hyperglycemia sign and symptoms and the hypoglycemia sign and symptoms. Having regular medical checkup to closely monitor the glucose level, urine protein, creatinine, blood pressure, weight, and ketone bodies if present in the urine. Dietary advice and monitoring. Dietary is very, very important during this period, or in this case of gestational diabetes, and this is why we give her a diet education. Dietary management is successful and will be successfully optimize the glycemic control in approximately 80% up to 90% of the patient with GDM. So if you ask me what is the first path or the first line to manage the gestational diabetes, I would say we start with the diet. First, we start with the diet, and fortunately this works for 80 up to 90% of the patient. Okay, after the diet modification and the diet changes, the glucose can be controlled, but unfortunately that would not work with the others, and if not, we start with insulin therapy with them. Okay, and we tell her that the recommended daily caloric intake range from 1800 to 2000. This should be divided into 3 groups as 40% up to 45% of carbohydrates, 20% to 30% of a protein, and 30% of fat. And total caloric intake should be divided into 6 meals per day, meaning she would have 3 meals, large meals, and 3 snacks. Avoid the food and beverages with added sugar, corn syrup, honey, any candies, and so on and so forth. Choosing high fiber food will help control your blood sugar and have regular bowel movement, and avoid the contraception. Okay, it's very important to notice the signs and symptoms of the hypo and hyperglycemia during the insulin therapy. As I mentioned, we need to tell the mother and teach her about the hypoglycemia sign and symptom and the hyperglycemia sign and symptoms. Okay, the postpartum care. The blood sugar will return to normal level within 24 up to 36 hours in some women, and insulin requirements are usually reduced by at least 50%. That is after the delivery, okay? Breastfeeding should be encouraged, of course, because the baby will develop what we call it hyperinsulinemia. So that will increase the risk for hypoglycemia. So the baby should be fed immediately after the delivery, either by breastfeeding, and if the mother cannot breastfeed the baby, the nursery nurse will feed the baby. and after that she will check the blood glucose of the baby. The operative birth, together with diabetes, predispose these women to infection and delayed healing, meaning if the mother having CS, cesarean section, that means she has a wound, okay? And this wound will put her at a higher risk to develop infection. So the administration of antibiotic may be useful and a preventive measure in this instance. Women should be offered a contraceptive advice so the optimum metabolic control is achieved prior to planning the next pregnancy. Okay, so it's important to give the mother contraceptive education so that she will control her glucose level before she gets the next pregnancy. For the neonatal care, as I mentioned, hypoglycemia, to prevent this complication, the neonatal blood glucose need to be assessed 1 up to 2 hours after the birth, and then every 4 up to 6 hours for the first 24 up to 48 hours. Regular feeding is encouraged, as I mentioned, to maintain the blood glucose of at least 2 millimole per liter. Observation of temperature, epic, speed, and respiration, and monitoring of blood sugar levels are important in the first 24 up to 48 hours. Any clinical sign together with the symptomatology such as respiratory distress, apnea, tachypnea, cyanosis, or irritability. So the fetus or the baby coming in a GDM mother, he needs or she needs a close monitor after the delivery to clear her of any kind of complication that may arise. And this is it for today. So we come back to our objectives. We identified the concept of high pregnancy, and we explained the factor contribute in high pregnancy, and we defined the gestational diabetes. What is the gestational diabetes? And recognize the risk factor of GD, which is the gestational diabetes, and its effect. And we discussed the management of the gestational diabetes. And thank you.